Hello, everyone. Good afternoon. This is Avash Kalra. I'm the course director for our Hepatology and Liver Transplant webinar series. Welcome to today's webinar. I will go ahead and introduce our speaker while we wait for a few more attendees to join, and then we'll get started. This is the last webinar of our 2024 series, by the way, and we're in the process of putting together the 2025 schedule, so we'll be releasing that in the coming weeks. And just wanted to thank everyone for attending, as well as all the speakers we've had during the year. So today's talk is on the updates in viral hepatitis in the outpatient setting. Our speaker is Robin Bricker Ford. She's an ambulatory clinical pharmacist specialist who works in our hepatology clinic, really an important part of our team and really helpful for all of us as we take care of our patients. And I will hand it over to Robin, who will go through today's talk. Thanks again. And Robin, take it away.
All right. Thanks so much, Avash. So as Avash mentioned, again, today I'm going to talk about updates in viral hepatitis in the outpatient setting, since that's my primary practice site. We'll just first go through some of these slides. This is giving you some information about the CME accreditation. I have no relevant financial relationships to disclose. Here's the information on how to do the evaluations, as well as some nursing hours. All this information is also on the webinar website. So with that, I will go ahead and get started. Today, for this presentation, I decided to focus on these 5 objectives. Notably, they are just updates in hepatitis B and C, since that is my primary practice area, and there's just not a lot going on with hepatitis A and Delta that I felt were relevant at this time. All right, so we'll kick it off with hepatitis B. And I'll start both these sections with touching base on epidemiological trends that we've seen and kind of where we're at. So this data was published by the WHO this year, and it's looking at 2022 data. And worldwide, we see that about 254 million people are estimated to be living with chronic hepatitis B infection, with 1.2 million in new infections every year, resulting in about 1.1 million deaths. In the United States, this rate is much lower, which is to be expected due to widespread use of hepatitis B vaccinations. The CDC estimates that in 2024, there are 1.5 million people living with chronic hepatitis B infection, and this was specifically adults that they categorized here, with 13,800 new infections, resulting in just under 2,000 deaths from hepatitis B-related causes, primarily cirrhosis and hepatocellular carcinoma. This slide here shows you data from the Polaris group. You'll see more references to this data, or the Polaris group specifically, throughout my presentation, since they do a really good job to classify epidemiological trends and just where we're at working towards elimination with these forms of viral hepatitis. So you can see here in this graph, it's showing you the global distribution of people living with chronic hepatitis B infection as of 2023. The countries in red and orange are going to have the highest prevalence. And in fact, really only one country, which is the Central African Republic, there in the middle of your map, has a prevalence greater than 10%. And as you can see here in the chart on the right, the countries with the most total infections include mainland China, India, Indonesia, and Nigeria. In the United States, though, after about a decade of really having stable rates of new acute infections reported in the United States, we've started to see a decline. So we first observed a decline in acute cases in 2020, which has been sustained for the last few years. And why we may suspect some of this is related to the pandemic with decreased testing and reporting, the fact that we've had this stable decrease it is promising that there are decreased rates of transmission in the United States. And what about hepatitis B screening? There have been new recommendations by both the CDC in 2023 and WHO in 2024. And these are really transitioning away from the risk-based criteria, which we used to do to recommend screening for hepatitis B, to a universal screening approach. So that is to test all adults. The recommendation is to use a triple panel test. So that includes a hepatitis B surface antigen, hepatitis B surface antibody, and the hepatitis B core antibody. And then ongoing risk-based testing for all pregnant persons, so in their first trimester, as well as people with ongoing risk factors. Additionally, new in 2024, per the WHO, all persons who test positive for hepatitis B surface antigen should go on to be screened for hepatitis delta. This is a universal screening recommendation. This is also paired with a new algorithm by the CDC, again, also published in 2023, which focuses on encouraging healthcare providers to do vaccine reconciliation and vaccinate all people with unknown history of immunity and screen as well. Just as a reminder, universal hepatitis B vaccination has been recommended by the CDC since 2022, and that is for all infants, unvaccinated children under 19, and then all adults 19 to 59. The recommendation to vaccinate adults greater than 60 is still on a risk-based basis. There are 4 hepatitis B vaccines, 3 monovalent and 1 that is combined with a hepatitis A component. The Hep B CpG, which stands for the novel adjuvant cytosine phosphoguanosine, is our preferred vaccine. And this is available under the brand name Heplisab-E, which I'm sure you're all familiar with. It's been FDA approved here in the United States in 2019. And it's given as a 2-dose vaccine separated by 4 weeks. And the reason why it's preferred now is because it does induce a significantly higher seroprotective response in adults, and that occurs much faster. So we see immunity with the surface antibody greater than 10 within 8 weeks, as opposed to the aluminum adjuvant comparator vaccines. So let's switch gears a little bit and talk about how clinical testing has changed for hepatitis B. And there are some old and new biomarkers that I want to discuss today. So as we're all aware, there are 2 sources of hepatitis B surface antigen. This is already part of our screening test, but one of the main limitations is that our current assays are unable to distinguish if the surface antigen is derived from integrated hepatitis B DNA or CCC DNA. And therefore, research has really turned its focus on looking at other new biomarkers that can better evaluate CCC DNA activity in the liver. So here are the 2 different sources of the surface antigen. And the new markers that we're really focusing our research efforts on are hepatitis B RNA and hepatitis B core-related antigen. And this is a composite of hepatitis B core antigen, hepatitis B E antigen, and the P22 core protein, which are all exclusively derived from CCC DNA. So really, while we're still trying to figure out the clinical relevance of how to incorporate these new biomarkers into clinical practice, which are not yet available for us to use outside of clinical trials, the research that has been done has shown that they can identify patients at risk for progressive disease and potentially predict relapse after cessation of nucleoside analog therapy. So therefore, while we'll see more of this in the future, today I'm just going to focus on looking at the quantitative hepatitis B surface antigen test. This now is available for us to order in the United States through Quest Laboratories. So generally a send-out lab for most people. And this is good information because a low hepatitis B surface antigen level, so around less than 1,000, is considered to be a marker for immune activation. And this is useful in patients with the low hepatitis B DNA level, so around less than 2,000, to help us differentiate phases of hepatitis B infection and potentially evaluate prognosis. And we first learned about this through the REVEAL study, shown here to the right. So this is not new. This data was published in 2011 and later updated in 2013. But this was really the first time we could see how these levels and thresholds related to disease prognosis. And what this chart is showing you here is that in 2,840 patients, the cumulative incidence of hepatocellular carcinoma was significantly increased in people that had a high DNA level greater than 20,000 and a high surface antigen level greater than 1,000. And that significantly dropped off for people that had a lower DNA level less than 2,000. So this did clue us into the fact that this DNA level can tell us a lot of information about disease prognosis, as well as factoring in this second piece of information. In addition to evaluating disease prognosis, quantitative hepatitis B surface antigen levels can also help us to monitor response to treatment and hopefully predict patients' response off of treatment. And we learned about this in the RETRACT-B study. So this was a multinational study performed in 1,552 patients that was published in Gastroenterology in 2022. And what they looked at is the response in patients who had chronic hepatitis B infection that were virally suppressed and E antigen negative, who stopped nucleoside analog therapy. So first, let's look at the chart on the left. And this was their primary outcome, which looked at the overall cumulative probability of surface antigen loss. So that percentage is on the y-axis. And that we see that at 48 months or 4 years from the time since stopping NA therapy, the surface antigen loss was 13%. So they further went on to try to predict patient variables or virus variables that can help us anticipate what are their chances of having surface antigen loss. So again, in these folks, they found that in people that were white, if their surface antigen was less than 1,000, their chances of having surface antigen loss, or their probability, was 41%, compared to if the surface antigen was greater than 1,000, it was only 5%. And then we see that people of Asian descent, if that surface antigen was less than 100, their probability of surface antigen loss was 33%, compared to 2% if the surface antigen was greater than 100. So they utilize this information to come up with clinical recommendations of who may be a good candidate to stop NA therapy. So overall, the authors concluded that the best candidates for NA withdrawal are virally suppressed, E antigen negative, of course, non-cirrhotic, and then in patients with surface antigen levels less than 100 across all demographics. And there's some other data that kind of pushes that level down to 40 potentially. So that was some interesting data that looked at, who may potentially be a good candidate to have definitive NA therapy. But what about new updates on who should be started on treatment? Of course, I'm sure you guys have all seen this AASLD guidance from 2018. It's pretty outdated at this point, but their recommendation of who to initiate therapy is based off of individuals who have an ALT greater than 2 times the upper limit of normal and a hepatitis B DNA level greater than 20,000. This is in people that are E antigen positive, with a lower cutoff for those that are E antigen negative. Again, I think we've all recognized that this data, we really need updates. This data no longer holds true anymore. And so in the meantime, we've looked to other researchers, other clinicians to give us an update on who should be started on therapy. So this simplified treatment algorithm was published in 2023 by a group of US physicians and experts, and they tried to simplify the treatment approach and really expand eligibility. So what they did is they recommend over here on the left that any adults greater or equal to 30 who have a hepatitis B DNA level greater than 2,000 and an ALT level that's under the upper limit of normal should be treated. Alternatively, if their age is less than 30, but their DNA level is greater than 2,000, and their ALT level is greater than the upper limit of normal, those folks should also be treated. So this is the first time we really saw age kind of incorporated into this treatment algorithm and into treatment considerations. Next, we have the Chinese guidelines. I always just kind of like to look at this because they are the first and really the only guidelines to take away a quantitative measurement of hepatitis B DNA. So rather, in anybody that's surface antigen positive who gets a DNA level, they simply look at if that patient has an undetectable level or detectable level, positive or negative. They don't care what the number is. Then they further go on to look at ALT. For any patients that have a detectable hepatitis B DNA level with an ALT greater than the upper limit of normal, those folks should be treated. On the flip side, if their DNA level is detectable, but their ALT is less than it's normal, then that patient may still be treated if they meet one of any of these 4 criteria. And you do see age is listed in here as well. So this really sets us up for the long-awaited WHO guidelines that were published in March of 2024. And really what they aimed to do with these updated guidelines is to expand eligibility of treatment and really simplify the process. So just kind of following through this treatment algorithm here at the top, they recommend to treat all adults and adolescents over 12 years old, including 12-year-olds, including pregnant and non-pregnant women that meet one of these 4 options for patient eligibility. So that includes people that have significant fibrosis, so F2 or greater, regardless of hepatitis B DNA level or ALT level. Or option number 2 is if they have a DNA level greater than 2000 and an ALT level greater than the upper limit of normal. And then the third just simply looks at risk factors. So this doesn't include a DNA level or ALT, but simply if the patient has the presence of any of the following, which include co-infection with HIV, hepatitis delta or hepatitis C, a family history of liver cancer or cirrhosis, or immune compromised, have comorbidities, or even extrahepatic manifestations, which can be difficult to ascertain being directly related to hepatitis B. Alternatively, the 4th option here is in the absence of being able to obtain a hepatitis B DNA level, if that patient has persistently abnormal ALT levels alone, they do recommend treatment. So this approach, and sorry, this is a busy screen, but just wanted to show you that this approach really came from 2 key systematic reviews that the WHO performed. And they have these tables and all of this data listed in their clinical guideline, which is a whopping 272 pages, so not a light read. But basically, these 2 key systematic reviews looked at clinical outcomes here in Table 5.1, as well as efficacy of antiviral treatment in this Table 5.2. And basically what they discovered is that there was an increase in disease progression for folks that had a hepatitis B DNA level greater than 2000 or an ALT above the upper limit of normal. So I just touched on a bunch of different guidelines. So what are we supposed to follow? How do we incorporate this into our clinical practice? Really, for the most part, we don't know exactly when the AASLD will provide us with updated guidelines, but we are starting to see a trend towards lowering the threshold to treatment and expanding that treatment access to pretty much anybody that tests positive for hepatitis B surface antigen. And the WHO has provided the most evidence-based recommendations regarding lowering those thresholds. So us as healthcare providers really must just use our best clinical judgment on a case-by-case scenario to determine who is an ideal candidate for any therapy in order to suppress viral replication to improve morbidity and mortality. Really, while we're waiting for curative therapy that's coming down the pipeline. So where are we with that? There are several new investigational drug therapies that target the hepatitis B life cycle shown here. I know this is a very busy slide. It's really just aimed to show you all of the different research approaches that are being investigated right now. So several of these therapies are being studied in combination with either our standard of care, so peg interferon or nucleoside analogs, or with each other, so multiple investigational therapies being used synergistically, really in search of a functional cure. And many of these have made it to phase 2 clinical trials. And really, we can kind of think of all of those different strategies being grouped into 3 different approaches. So they either inhibit viral replication, boost immune response, or lower viral antigen burden. And the ideal combination of how to use these together is still not well understood. But I did today want to just touch base on a new medication, bepirovirsen, or Bepi for short, which falls into this category here. It is an antisense oligonucleotide, or ASO, and it targets the hepatitis B mRNA to lower the viral antigen burden. Based off of data from 2 different phase 2 clinical trials, it was granted US FDA Fast Track designation earlier this year and is currently in 2 ongoing phase 3 clinical trials. So I just briefly wanted to talk about one of those phase 2 trials called Be Clear. And this was a randomized clinical trial, and it looked at people, or it included people with chronic hepatitis B infection that were either receiving stable nucleoside analog therapy or were not currently on any therapy at all. And they took those 2 groups and they randomized them in a 3-3-3-1 ratio into 4 groups. And then these 4 groups, these groups received bepirovirsen in different dosing strategies. So for the sake of time, I'm just going to have you guys focus on this top group, group 1. Everybody in this group either continued NA therapy or did not, but they all got bepirovirsen 300 milligrams, which is a subcutaneous weekly injection, for 24 weeks. And then they were followed for an additional 24 weeks after the cessation of therapy. And what they found, I first want to focus on this top graph on the top left. This was the primary composite endpoint. And that composite was looking at a hepatitis B surface antigen below the lower limit of detection and a DNA level below the lower limit of detection. So what this is showing us when looking at group 1, so just this first part of the graph, is the percentage of patients who achieved this composite primary outcome. And those that continued, that were in the NA group plus Bepi, had a 9%, achieved this in 9% of patients, versus 10% of patients that did not continue the NA and received Bepi monotherapy. So this is really exciting because it was really the first study to demonstrate an increase, albeit small, in functional cure over interferon or NA therapy. And then next, I just wanted to draw your attention to this table on the right. So what this is showing you is the percentage of patients on the y-axis and the different hepatitis B, different categories of hepatitis B surface antigen quantification. So these top bar graphs are people who received NA therapy compared to those who did not receive NA therapy with the Bepi. So at baseline, it's not surprising that a very large percentage had a high hepatitis B surface antigen level. So these are going to be the orange colors, and that's categorizes a surface antigen level of greater than 1,000. But once Bepi was started to be given, we see a significant decrease in the percentage of patients that have these high levels, which was sustained through the follow-up period at the end of treatment, even after Bepi was discontinued. So overall, these authors conclude that 24 weeks of Bepi, 300 milligrams weekly, resulted in a sustained surface antigen and DNA loss in 9 to 10% of participants. And a baseline surface antigen level of 3,000 or less was a strong predictor of response. All right, so hopefully we have some new medications coming down the pipeline that will help us achieve our WHO elimination target. So if you guys aren't familiar with this table, this was published in 2016 by the WHO, which outlined specific elimination targets for hepatitis B and C, focusing on prevention and then treatment, incidence, and mortality. And then they segregated these targets based off of the year 2015. So basically a baseline, and then a 2020 target and a 2030 target. And this is how we're doing so far. Again, this is data from the Polaris group. And this map is showing us how well basically the world is doing towards meeting these targets. And every single country is red, meaning that they are not on track. What about in the United States? So here, again, this is data from the Polaris group, which is showing our anticipated progress towards achieving these targets. So 90% of patients being diagnosed, 80% of those patients treated, a 65% reduction in mortality. And based off of where we're at, so the target here is this yellow line of the year 2030. They don't anticipate that we'll achieve these goals until the year 2051 at the rate that we're going. So why might that be? Here's a look at the care cascade for hepatitis B infection. And it's kind of showing us the different gaps of what's happening in this cascade. So for all of the patients who test positive for hepatitis B surface antigen infection, which is this red bar, we do see a significant drop in the patients who are eligible for treatment. And that's really what we've been trying to close that gap with these updates in clinical guidelines for expanding eligibility of treatment and really simplifying that process. The other gap here is getting those folks who are eligible for treatment actually on treatment. And really what we need to do is have expanded screening and treatment efforts, improve linkage to care, and focus more resources on the unmet needs for hepatitis B. So those include optimization and implementation of perinatal care in order to reduce mother-to-child transmission. So really focusing on neonate immunoprophylaxis with the hepatitis B vaccine, with or without HBIG, and then appropriate maternal antiviral prophylaxis. There's a lot of data out there looking at the optimal time to start maternal antiviral prophylaxis. Another unmet need is really trying to develop more tools and diagnostic markers that can help us predict the risk of hepatitis B related liver cancer. And finally, to better define finite therapy for chronic hepatitis B infection. Who might benefit from this? What should our thresholds be? How do we monitor this, et cetera? All right, so let's move on to hepatitis C with the last 15 minutes we have. So again, touching on epidemiology here, worldwide, it's estimated that 50 million people are living with chronic hepatitis C infection, with 1 million new cases resulting in 242,000 deaths. In the US, you see these numbers are significantly higher than with hepatitis B. So the CDC estimates 2.4 million people are living with chronic hepatitis C infection, and that number actually ranges up to about 5 million. Just given the difficulty in estimating the prevalence of hepatitis C due to underreporting and underdiagnosing. The CDC also estimates that 67,400 people or 400 new cases occurred in 2022, resulting in 12,000 deaths. Here's a map of the global distribution by the Polaris group. And you can see a little bit more color here. So again, the countries in red and yellow have the highest prevalence. And then the countries with the most infections are listed on the right. And as you can see, the United States is in the top 5. However, since we've seen a big uptick in acute infections of hepatitis C in the US since 2015 due to the opioid crisis, but that has started to stabilize. We saw that first occurring really in 2022 with a slight reduction in reported new cases. Again, this could be related to decreased testing and reporting from the pandemic, but it is promising that we're starting to see this taper off. So who is getting hepatitis C in the United States? We started to see this kind of shift to a bimodal distribution where males, specifically males aged 20 to 39 years old, are getting infected with hepatitis C. And persons who inject drugs or PWIDs account for 57% of those folks. Because of these changing demographics, the CDC did recommend universal hepatitis C screening in all adults as of 2020, as well as in every pregnant person during each pregnancy, and then targeted screening for people with ongoing risk factors. Currently, we use a two-step diagnostic sequence for hepatitis C infection, which starts with checking a hepatitis C antibody. And if that's positive, we go on to do a confirmatory test with a hepatitis C PCR to quantify the RNA level. However, this has many limitations with this process. It can miss early infection during that initial window period of 0 to 70 days before the antibodies are detectable. And it requires multiple tests and clinic appointments, where we often lose patients to follow up during this time when they would have to return for a second blood draw. And finally, it requires access to a phlebotomist and clinical laboratory. So because of that, there's been a lot of excitement around hepatitis C point of care tests. The point of care hepatitis C antibody test here shown on the left has been around since 2010. It just takes a finger stick put on this test, so it could be done really anywhere. And you get a time, you get a result in 20 minutes time. We've still been incorporating this into different areas, but really the excitement now is around the point of care hepatitis C RNA test, which is new in the United States this year. This test has been widely used in Europe for the last several years, and we have a lot of good research around it, but it was just FDA approved here in the US over this summer. And it uses a whole blood sample by finger stick to get a result in 41 to 60 minutes with about 99% sensitivity and specificity. But the downside here is really just access to the machine to run these samples and the cost of that machine, coming in at about $21,000 per system and $15 per kit. But still, this is very exciting that we have access to this now. And really trying to figure out how to use this in our community, the CDC has published these considerations for how to implement point of care testing, which was actually just published in October 2024. Key takeaways really of what they addressed were who can benefit. So again, those folks that don't have access to a phlebotomist or a clinical laboratory, or may not have access to longitudinal follow-up in a clinic. They also focus on where this can best be utilized. So co-localized treatment, primary care clinics, health fairs, non-clinical settings like syringe exchange programs could potentially really benefit from this point of care testing in the community or in remote areas where there's just not access to these things. And there is a potential for this same day test and treat approach, but there are still some barriers to implementation. First of all, being the lack of a point of care hepatitis B test that's available in the United States. So without this information, we can't rule out hepatitis B co-infection or risk for hepatitis B reactivation, which really limits our ability to do the whole same day test and treat approach. Further, as mentioned, cost and funding for the machines, as well as the best strategy to document results in a medical record and then link those patients to care. So what about updates in treatment? Not a lot going on, but the AASLD has published these simplified hepatitis C treatment and monitoring guidances. It's these one-page sheets that are aimed to be used really at a generalized level of care. So they now recommend treatment with a pan-genotypic regimen to eliminate the need for checking a genotype, and then really minimizing the pre-treatment assessment and on-treatment and post-treatment follow-up. This approach widely comes from data from this trial, the MINMON study. MINMON standing for minimal monitoring, which was published in the Lancet in 2022. So this was a phase 4 open label trial where, again, there was no pre-treatment genotyping, and everybody enrolled in the trial was given Epclusa or Sofosbuvir, a pan-genotypic regimen for 12 weeks. And they were also given all of the medication upfront. They did not have to follow up for refills or anything like that. So there were no scheduled visits or laboratory monitoring, and there were only 2 points of remote contact during this entire study. So researchers or investigators contacted the patients at week 4 for adherence, and then week 22 to basically schedule their week 24 follow-up laboratory testing for SVR. And what they found at this SVR visit was that 89% of participants reported taking the medication 100% of the time. Further, 95% of people who initiated treatment achieved SVR, which is consistent with the standard of care. And finally, only 4% of participants reported a serious adverse event, and none of them were really deemed to be treatment related. All right, and then what about the future of hepatitis C treatment? Where are we going with this? I just found this to be kind of interesting. It's still kind of in its infancy, but reported at the liver meeting and EASL this year was this group out of the University of Liverpool, and they did a preclinical pharmacokinetic assessment of a long-acting injectable formulation of lenacapavir and pibrenizumab. So in this preclinical trial, they administered this injection to rats and identified that the plasma concentration of drug was sustained over a period of 13 weeks, which far exceeds the typical treatment time of 8 weeks right now in humans. In this trial, there were no hepatic adverse events effects to the rats, but certainly future work is needed to determine if this is safe and will be efficacious in humans. So potentially more to come on this. All right, so where are we at with our progress towards the WHO elimination targets for hepatitis C? The good news is we're doing a little bit better. Here's the global map of how countries are doing, and those in green are on track to meet their elimination target. We've got these 13 countries here. Unfortunately, the United States is still not on track. So how does that break down? We are doing well with improving our screening and diagnostics, treating people who have been diagnosed, and then that is associated with the decrease in mortality. But really the area that we're lacking is improving the rate of new cases. So getting that incidence down to 80 or by 80%. And the Polaris group here estimates that we aren't on track to meet that target until the year, again, 2051. Breaking that down by taking a look at the care cascade, again, we see a very large percentage of people who are infected with a significant decrease in those that are diagnosed. What you're looking at here is the darker colors that represents data since the start of the year, so since 2024, and the lighter shade represents data since 2015. So we have improved these numbers, although you can't really tell this year. Of those diagnosed, we still do have a pretty large gap in patients who are treated, although those that are treated do have a very good rate of SVR. So overall, acute cases of hepatitis B and C do seem to be stabilizing and even declining in the United States, but this of course remains a significant public health concern. The CDC has recommended simplified universal hepatitis B and C screening in all adults. And there are new modalities for hepatitis C testing in the community using point of care tests. We're still trying to work out how to really implement that into clinical practice, given the newness. New hepatitis B viral markers for evaluating CCC DNA activity include looking at the quantitative hepatitis B surface antigen, the HB CRAG, and the HBV RNA levels. And that quantitative surface antigen test is now available in the United States. Many new hepatitis B investigational therapies are being studied. And again, they're looking at inhibiting the viral replication, lowering viral antigen burden, and boosting immune response. And bepirovirsen, or Bepi, is a novel ASO that's currently in phase 3 clinical trials with hopes for at least an improved rate of functional cure over our current available therapies. With all of that, though, the US is still not on track to achieve our hepatitis B and C WHO elimination targets. And so we really do need to focus more efforts on expanding screening, treatment, vaccination for hepatitis B, and linkage to care in order to close our gaps in the care cascade. So with that, I want to thank you all for your attention over this lunch hour and open it up to any questions that you guys might have. All right, so pulling up the chat here. If anybody has any questions, please feel free to unmute or just type them in the chat.
Robin, thanks for the presentation. This is Avash. While we're waiting for others to maybe ask some questions, I guess do you think that it's feasible to aim for kind of what we did with hepatitis C and achieve full cure? I mean, obviously, it's part of the goal of all the investigational trials that you talked about, and a lot of meetings about that at the ASLD meeting recently. But I guess just curious if you think that that's feasible or some direction we might go in.
Yeah, I mean, I think that's a really difficult question. Obviously, researchers think it's feasible, and I think there's some promising data out there. What we're still looking for is really looking at these new directions. So immunomodulatory therapy is really kind of the big one, and how we can leverage some of these modalities synergistically to achieve this functional cure. So I think with the new therapies, we'll have a higher rate, but I don't know if it's going to be the standard to expect functional cure in everybody. Hard to know though. It would be very exciting if we get there, but I think it's still a long road. Okay, it looks like Christy said in the MINMON study, it looks like there was a greater percentage of patients who achieved SVR than the percentage of patients who were 100% compliant. Is it known how non-compliant or non-adherent these patients were if they were not 100% compliant? That's a good question. I could look at how those numbers break down. They may have just done the intention to treat analysis for SVR rates on only people that reported compliance. I don't exactly know how that broke down, but that is a very good question. And these numbers really translate to what we were seeing in clinical trials or following a more strict follow-up schedule. So for the longest time, this hepatitis C as a disease state was much closely monitored than it is now. And I think the whole point of the MINMON study is they're seeing similar results to whether we have all of this follow-up versus if we don't. And so the data is supposed to be encouraging basically to promote expansion of treatment to people who may not be as compliant with follow-up or have the capability to do that, to show, hey, we can still treat these people, they can still achieve cure even if we aren't following them so closely. And then it also decreases the cost and resources from healthcare providers and the healthcare system to do all these additional tests and appointments. All right. Well, my information is on this slide and on the website as well. If anyone has any additional questions that you think of, please don't hesitate to email me or reach out. Find me in clinic.